oropharyngeal dysphagia, a systematic review and meta-analysis. It has not been fully elucidated whether a decreased tongue pressure is associated with oropharyngeal dysphagia and swallowing function. In the previous systematic review, measurement of tongue function with pressure measurement devices were excluded because the method was not considered to be in routine clinical use. This time, we performed a systematic review and meta-analysis to determine whether maximum isometric tongue pressure, ICMIP from now, reduction is useful in the diagnosis of oropharyngeal dysphagia, or in other words, swallowing disorders. This is the clinical pathway. This study tried to find out usefulness of MIP as screening tool for swallowing disorders. Methods. We performed systematic review of diagnostic test accuracy. Inclusion criteria was adults suspected swallowing disorders. It includes patients with a background of underlying dysphagia with history of cerebral vascular disease, neuromuscular disease, and so on, and healthy older people with aspiration. The target condition was set as swallowing disorders with videophlorography or FEES. Swallowing disorders were defined to include aspiration, valvular residue, and piriform sinus residue. Our search strategy is shown in this slide. We identified 613 records from electronic search of database or other sources. After removal of duplication, 3 reviewers joined for fast screening, with titles, and 309 records were excluded. For second screening, 2 reviewers read full text of 133 records and chose 61 records as eligible. The review team sought detailed data, and 6 studies were included, 2 qualitative syntheses. This table shows the list of included studies. We performed risk of bias assessment for 6 studies, which was eligible with full text review. The author, MN, used the QUADRAS-2 tool. With patient selection, high risk of biases were recognized with 3 studies. As the inclusion of this study was adults suspected swallowing disorders, the studies which included already diagnosed dysphagia were assessed as high concerns for applicability. This time, we excluded still 2013 from quantitative synthesis with high risk of bias and low applicability on this study. We excluded Morfento 2018 from quantitative synthesis because we could not reach sufficient data to make 2x2 table. Here we show the result of meta-analysis for the outcome of swallowing disorders. The definition of swallowing disorder are set as the outcome which include aspiration and pharyngeal residue. The figure in the right side is the forest plot. The sensitivity of MIP to screen swallowing disorders was shown as between 44% to 86%. Overall sensitivity was 65%. This is ROC curve for outcome of swallowing disorders. This is the first plot of aspiration with 5 ml thin liquid. The overall sensitivity was 70%, specificity was as low as 29%. This is the first plot of varicula residue with 5 ml thick liquid. The sensitivity was 74%. This is the first plot of piriform residue with 5 ml thick liquid. The sensitivity was 83%. Discussion. The low sensitivity of 65% for swallowing disorder indicated MIP reduction is not sufficiently useful to screen swallowing disorders. From the relatively fair sensitivity of pharyngeal residue, MIP may be useful for predicting pharyngeal residue. Conclusion. The result of this systematic review suggested that MIP reduction is not sufficiently useful to screen swallowing disorders. MIP may be useful for predicting pharyngeal residue, which may be helpful for suppressing radiation exposure for patients and for therapists planning rehabilitation programs. To determine the usefulness of MIP in the diagnosis of oropharyngeal dysphagia, more evidence from qualified studies is required. This is the end of my presentation. Thank you very much for listening.
Thank you, Dr. Nakao, for your informative presentation. So there's one question came in. I think measuring temperature in older patients with dysphagia risk is very important in clinical setting, in spite of the relatively low sensitivity. However, the measurement is not covered by health insurance system in Japan. I should be covered, I think. What do you think about that?
Thank you very much for the question. I think the measuring of temperature is covered now for the dysfunction of or lower function of oral, how can I say, function, I guess. So actually, in some how can I say, in some diagnosis for especially perhaps dental clinics, it's covered, but not for the dysphagia.
Thank you. Other questions? So I think dysphagia is multifactorial, and temperature is. What do you think? What is the hypothesis? Temperature to follicular phase dysphagia.
Yes. This is a thank you, Professor Hanayama, for asking good question. Well, that was my goal, or how can I, to know to do this study. So to find out the relationship between pharyngeal dysfunction of dysphagia and the temperature. So the result of this study was relatively near from my hypothesis. So I supposed that perhaps it's hard to find direct effect from just temperature, but it can cause varicula residue because of the anatomy.
Okay, do you think it improves by adding temperature to other screening tools?
For dysphagia?
Yeah, for dysphagia screening.
For dysphagia.
Or diagnosis.
Actually, I checked for the screening as a screening tool, and well, I couldn't find enough, how can I say, enough data to increase the possibility.
Okay, thank you. So, so time is over. Thank you for Dr. Nakao.
Thank you.
The last paper is presented by Dr. So, titled Risk of Dysphagia After Liver Transplantation. Please start your presentation, Dr. So.
Thank you for your kind introduction. Good afternoon. I'm Kyung-chun Seo. I'm a physical medicine and rehabilitation physician and a fellow at Asan Medical Center, South Korea. Please start the video. Hi, my name is Kyung-chun Seo. I'm a rehabilitation medicine fellow at the Asan Medical Center. I'm really grateful for this opportunity to present our work. The title of the research is Risk of Dysphagia After Liver Transplantation. I have no relevant financial relationship to disclose. Liver transplantation is widely known as the standard treatment for patients with end-stage liver disease. As post-transplantation survival and clinical outcomes increased, outcomes related to complications and quality of life after surgery have become concerns for many transplant recipients. Dysphagia, a disorder of deglutition, occurs when food or liquids are not carried safely or properly through the aerodigestive tract, and previous studies have shown that symptoms of dysphagia can negatively impact on a patient QOL. Dysphagia is also associated with poor outcomes and can lead to serious health-related complications such as aspiration pneumonia, dehydration, weight loss, and malnutrition. Among various examinations, the video fluoroscopic swallowing study is the gold standard diagnostic tool. The aim of this study was to investigate the characteristics and risk factors associated with dysphagia after LT using VFSS result. This is a single-center retrospective observational study from January 2010 to May 2015. LT recipients who had undergone VFSS during this period were included. Patients under 20 years old with a previous history of dysphagia or cognitive impairment were excluded from the study. Potential risk factors associated with dysphagia were collected from patients' medical records, including age, gender, body mass index, body surface area, smoking history, previous mental status, length of stay in the hospital, and other comorbid medical conditions prior to surgery. The dataset also included the following: primary diagnosis, child Turcotte Fuse grade, mother for end-stage liver disease score, pre-operative hematologic data, and presence of cirrhosis-related complications. Swallowing assessment included bedside swallowing assessment and VFSS. In bedside swallowing assessment, abnormalities in conscious level, speech, lip sealing, tongue control, chewing, laryngeal function, gag reflex, vocal cord, and voluntary cough were evaluated. In VFSS, patients were given 5 barium packages to swallow, twice for each diet, and images were analyzed by 2 experienced physiatrists. LT recipients were divided into 2 groups, dysphagia group and no dysphagia group. Categorical data were compared using the chi-square test or Fisher's exact test, and continuous data were compared using a t-test or Mann-Whitney U test. Univariate logistic regression analysis and multivariate logistic regression analysis were also performed. Of a total of 72 patients, 48 were diagnosed with dysphagia using VFSS. 57 patients showed abnormalities in bedside swallowing assessment. Tracheostomy tubes were found significantly more in patients with dysphagia than those without dysphagia. Patients with dysphagia needed more renal replacement therapy due to renal failure. The mean MELD score was higher in patients with dysphagia than patients without. Levels of creatinine and CLP were also higher in patients with dysphagia. However, there were no differences in primary diagnosis, cirrhosis-related complications, or operative risk factors between two groups. The univariate analysis showed that there were 7 factors at a level of p-value under 0.1, including gender, presence of tracheostomy tube, dialysis, MELD score, serum albumin, and CLP. The multivariate analysis showed that male, presence of tracheostomy tube were independent risk factors for dysphagia. Patients with high MELD scores showed significantly more penetration or aspiration than those with low MELD scores. The result of Asian norms revealed that patients with low MELD scores were more on oral feeding than patients with high MELD scores. This study has several limitations. First, this was conducted retrospectively, which have limitations in that only previously documented variables were analyzed. Second, the data in our study were obtained from a single medical center, not various medical facilities, and the result of our study may be limited. In addition, we only included patients who have been consulted for VFSS. Therefore, we could not investigate the exact instance of dysphagia after LT. Prospective studies with a larger sample size identifying the true incidence of dysphagia after LT may be needed in the future. In conclusion, this is the first study to investigate characteristics and risk factors associated with dysphagia in LT recipients. This study recommends that a swallowing evaluation be given in LT recipients who are at high risk of dysphagia when oral nutrition is considered. As I bring this presentation to a close, I once again thank you for allowing me to present this study.
Thank you, Dr. So, for your wonderful presentation. So, any questions? No questions have come in. I don't have any experience of a liver transplantation patient, but why do you have many dysphagia patients among liver transplantation? So what's the mechanism of causing dysphagia in liver transplantation patients?
I'm really sorry to make a different mechanism, but I guess like sarcopenia or acquired weakness related to dysphagia in liver transplantation. And I also guess tracheostomy presence may associated.
Other questions? What is the indication of video fluoroscopy among these patients? You did all patients or symptomatic patients?
Actually, no. Yes. In this period, a total of 2,235 patients were received the LT. However, only 72 patients were undergone reappraisal because we referred this patient because of aspiration event or the symptom of dysphagia or some general condition, general weakness.
One question came in, so I listened to the presentation with great interest. What were the reasons why male patients had more dysphagia?
Really, I have no idea about that. And in further study, I'll deal with this causality. Thanks for the question.
Okay. Other questions? So thank you, Dr. So, for nice presentation. So all papers are presented. I appreciate all speakers and participants for attractive presentation and valuable discussion. So it's time to close this session. Thank you for participation in this session. Thank you so much.